the lung volume reduction surgery, emphysema surgery, is really something that's been a long project. I started it somewhat by accident back in the early 90s when I was asked by our Society of Thoracic Surgery. There was a guy doing some of this, not exactly the same, but some of the surgery out in California. So myself and 3 other thoracic surgeons went out there and spent a week and kind of watched what he was doing. And then we ended up putting together a prospective trial or study to look at some techniques for emphysema. Things have changed a lot since then, so what we did back then worked, but just a little bit. But that's what sort of started my interest in surgical treatment for emphysema. And since then we've evolved through a lot of different things, and but we've had a program here since 1993, I think. Well, what happens with the emphysema is these people get very hyperinflated with their lungs, meaning they get bigger. So as it destroys part of the lung, it actually stretches like a balloon being blown up inside their chest. The average patient that we operate on for emphysema, their lungs are over twice the size they are supposed to be for those people. So as they get really big, what they do is they push down on the diaphragm, which is the muscle that we use to breathe. So when we take a breath in, that muscle sort of, it's curved, it straightens out, it helps pull air in, and then it goes up and helps push the air out. When the lungs become hyperinflated or too big, they just cause those diaphragms to be flat and they don't work anymore. So with the surgery, the ideal patients have this badly destroyed part of the lung, but in a localized area. And we basically go in and take that area out, shrink the lungs back down, the diaphragms come back up and work again. Well, it's something a little bit unique. I mean, there's only 5 programs accredited in the country, so you wouldn't really necessarily think that Springfield would have 1 of 5, I suppose, but it's an area we've had a great deal of interest in. So it's not something that is available in many places. We get patients from all over the place that come for this. Mostly our contiguous states, but I think we've had patients from 26 different states come here to have this done. Now we're much better able to target where the disease is, and then we take it out with stapling devices through small incisions. We go in, called thoracoscopy, but usually 3 little incisions. We go in and look in and take it out. And we take out more, do more than what we did at the very beginning. It works very well. We do have a number of research things going on where we're putting endobronchial valves bronchoscopically in without incisions to try to essentially stop the air you breathe in to go to the bad areas and direct it to the good areas. I mean, for me, this has been a bit of a lifelong project, so I was proud to be selected. It wasn't something I was sitting in the crowd expecting, though, to be honest with you. I was probably as surprised as anybody about it.